So we go to the next presentation now by Dr. Aftab Khan, extremely high pressure balloon, how safe and effective, please.
Yeah, I'll just ask, good afternoon, Dr. Imad and Dr. Sarat and the rest of our colleagues. I'll just do a screen sharing. My talk was basically on the use of a high pressure non-compliant balloon. This was a case that I thought would generate some amount of discussion. This is something quite common, uncrossable undilatable lesion. And the clinical profile of my patient was a 72 years old hypertensive diabetic lady. Presentation was with crescendo angina with resting STD changes in the inferior leads and mild hypokinesia in the inferior wall with an ejection fraction of 50%. Cardiac enzymes were normal and the creatinine was normal. This lady was on maximum anti-anginals and we took her up for an invasive procedure. This is the left system. There's a very moderate disease in the mid part of the LAD, and the right coronary artery can be seen retrograding till the mid part. And this is the antegrade shoot in the right side. And you can see the tram track appearance of the calcium there. And there's a proximal total occlusion with a faint antegrade filling through intracoronary collaterals possibly. So there's possibly a faint channel there. Another thing of note is that there's no side branch that I can use to sort of use an anchor balloon. So I started off with my standard technique of using an Amplatz guide, and because of the channel there with a micro catheter, this was a fine cross, tried using a Fielder FC wire, and this did not cross, and upgraded to a Gaia second with a micro catheter support, and this went through. Now the issue is that after the fine cross would not cross, and we tried another balloons, 1.1 into 5 across CTO. And the smallest in size, presently the Nick Nano 0.8 into 5 would also not cross. And the guide would just back off at the time of pushing the balloon down. So this is something that we need to change into something different. And the Tornus is a tool that I think all of us should have in our labs, because this is a catheter which a 2.1 French would sort of, if can dive through, would give you an ID. So here what you can see is that the Tornus has gone through, and it has moved to this part here. Oh, I think it's one sec. Yeah. So this is the Tornus, and you can see that it has made advancement. It has gone till the mid part of the right coronary artery. The Tornus gives you an idea of almost around 0.024 inches, and this can get a balloon down then. And usually what I do is that when the Tornus is across, you'd also exchange with a wire here. So you take out the Gaia and put in a more support wire, usually to be an all-star. But here, because the Tornus was not advancing beyond the midpoint, I did not want to lose wire support. And that's the reason I proceeded with the across CTO balloon, which now, after the Tornus has made a passage, can now go down and make dilatations in the mid part. And then we could upsize to a 2.515 balloon. But this is the part which the Tornus did not cross. And this is the part which is unyielding. And you can see that a non-compliant balloon is still doing a dog boning there at 22 atmospheres. And at the end of this, when we have done this, this is what we have. There's an unyielding lesion in the mid part, and we have unyielding lesion in the proximal part too. Well, this was a case done almost 2 years back when, we did not have all the technologies as we have today. And this was a time that FlexTome was something that I tried. It was a 3.6 FlexTome, which I tried that time, and then this would also not cross, despite being on an all-star support wire. And I think we can debate whether FlexTome has much role in a calcific lesion. We all agree that it has role mostly in the fibrotic lesion. Well, then the next step was to upgrade to a rotor. And then this was a rotor with a 1.5 burr after putting in a temporary pacer. And this did a lesion in the mid part. The mid part was again polished with a 1.75 burr. So upsized to a 1.75 burr for the mid segment of the right coronary artery. Now, post-rota, this was still the lesion that we had. And the FlexTome, which initially could not track down, now could move down post-rota. And I did dilatations at 10 to 12 atmospheres in the proximal and the mid lesion. Now, again, the mid lesion, though the balloon opened up at 12 atmospheres, and this is a 3x6 FlexTome, they still seemed a part that was unyielding. And this is the angiogram. And you can still see that there is a dissection, as you'd expect with a FlexTome, in a proximal part. And there is the unyielding part of the mid RCA, which is still not opened up. So this is when the OPN NC balloon, which is the ultra high pressure balloon, was used. And you can see that this is a 310 NC balloon at 45 atmospheres. So the trick that I normally use, and this is what the recommendations are, that when you're using it for a pre-dilatation, you always need to downsize the size to a 0.5 millimeter less than the expected vessel size. And when you're doing a post-dilatation, then it is a 1:1 sizing. So here it was a 3x10 at 45 atmospheres, and this cracked the lesion. The proximal lesion, the proximal artery, even though there was a dissection there, I still felt that the artery proximal is a 4O, and therefore a 3O balloon safely at 40 atmospheres would give me the confidence that the lesion is opening up. And this is what it did. We did not have the lesion opened up at 40 atmospheres. And this was the lesion post-OPN balloon. 2 stents were used to cover the lesion, and a 4 proximally and a 3.5 distally, and a 4 non-compliant balloon post-procedure to do a post-dilatation in the proximal part. And this was the final result that I left with. There's a small spicule which is still sticking out in the proximal part. I did an IVIS. Unfortunately, that was on a demo machine, which I do not have access to now in this COVID era, but there was a good MLA there. And that's the reason we accepted that spur without getting worried about it. So as long as you have a good MLA without an unopened area of the stent, we really don't need to worry, because calcium is something that we may not be able to completely get rid of. And this was how the artery looked at the end of the procedure. We've had this discussion, and we know that there is a scoring system when you use our OCT. And we now know that an arc of calcium, which is greater than 270, or which is long and deep, more than 5 millimeters, and thickness of more than 0.5 millimeters and more than 5 millimeters long, well, you need something beyond this. You probably need a lithotripsy or an NC balloon, as we talked about now. But with uncrossable lesions, these are all devices that are a little bulky, and you need to have a passage before you can get these devices down. And an IVIS or a rota is something that we may need to prepare the bed prior to doing this procedure. The patient has been clinically angina-free for the last 2 years. She's been unwilling for an invasive angiogram, but that is something that we'd have liked to know the lesion status. She's had a dobutamine stress echo because of a prior to an elective knee replacement that she has done 3 months back, and that was, the echo was normal. So this OPN ensign balloon, which I think all of us should have in our armament now, it has it's a double layer balloon. It has these markers which tell us where exactly it stays, and it has sizes from 2.25 to 4. And the advantage of this is that it does not grow much. So unlike a normal NC balloon or a semi-compliant balloon, where you could get a dog boning effect, this grows uniformly, and there's no overexpansion. So by this, you prevent the risk of having a rupture. You prevent the risk of having edge dissections, which are very common when you have unyielding lesions with a non-compliant balloon. So my learning points would be that you need an adequate guide support and a wire choice when you're tackling lesions like this. Uncrossable lesions, well, we have other things that you could use. Here I used a fine cross. If I had a caravel, for example, I'm not certain whether a caravet probably could have walked in. A tonus usually gives you an idea of at least a 0.22 to 24, and that gets you most of the devices down once you get a tonus across. Post-rota, a rota basically does to modify the plaque, but you may need to prepare your lesion again with either a high-pressure balloon or a scoring balloon or a flextome. So this would be my priorities now, probably now that we have a high-pressure balloon. A post-rota, usually in calcific lesions or unyielding lesions, it's a high-pressure OPN balloon that is used first rather than using a flextome. Flextome we reserve mostly for fibrotic lesions or in-stent restenosis, where your fibrotic burden is likely to be greater. A high-pressure OPN balloon is useful in calcific lesions. Well, we use it mostly for pre-dilatation, but yes, you can also use it for post-dilatation. After you had a stent which is deployed and you've not noted calcium and then you get stuck, you can use it for post-dilatation. But again, as I said, well, be careful of the size. Pre-dilatation, usually it's a 0.5 millimeter downsize. With a post-dilatation, you would go 1:1. You go to 20, and then we gradually increase it slowly to reach 40 to 50 atmospheres. Intravascular lithotripsy is an option, but we had it just this Jan in India, and we did not have it 2 years back. Imaging, yes, is a definite asset. Well, it helps you to plan what tool to use. And as I said, the arc of calcium, the length of calcium would help you to understand which method you want to tackle. And post-procedure, it also helps you to understand that you have an adequate MLA. And this is something that has a disease outcome in terms of long-term outcomes. You also get to understand about unopposed stents. And this is what has a outcome in terms of acute stent thrombosis. Malopose stent, not so much in terms of acute stent thrombosis, and you get it mostly, it has an effect in late stent thrombosis, but it's the unopposed or unexpanded stent that is mostly important. If you do an imaging, this is what you get to see. And it's important to understand that we need to combine debulking strategies for preparation and treatment. A rota may have to be followed by an opium balloon, or an IVL may have to be followed by an opium balloon, because these are complementary, and you may have to have all these techniques in your lab if you want to tackle a patient successfully. So I'll stop here, and I'm open to questions. Yeah.
Thank you. Thank you very much for this beautiful case and summarized. I think we do not have yet Molasari.
No, he's not coming.
Okay, so we can discuss, just have some question about the last presentation, and because of time, I think we have really very few minutes. I would like to ask Dr. Khan about the potential complication with the use of so high pressure balloon.
Yeah, so I think, as I said, it's important that we size your balloon size well. So as long as you are keeping it less than 0.5 millimeter, less than than the vessel size in a pre-dilatation, and you go to 20 atmospheres and then go up slowly, we've not seen any problems here. In fact, when you use a non-compliant balloon, you are more concerned because of the fact that you get a dog boning, or your lesion can open up on the side where there's no calcium, and the risk of rupture is much greater. So in fact, with an opium high pressure balloon, we are more comfortable rather than the non-compliant balloons, and the high pressures are something that we're not really concerned about. And the double layer of the balloon really gives us that much protection.
Actually, I'm concerned about the heavy calcified lesion. When you are debulking, sometimes the calcium will perforate when you are inflating balloon. And if you have this kind of balloon at 40 atmospheres, that the debris of calcium can perforate after debulking or during debulking. Could be the only thing that it's not related to only high pressure and the very high pressure, also with other devices, that mean with less pressure inflation can happen. And this not so frequently, but could happen. Okay. I think we can conclude this session. It was very, very beautiful session, very instructive and very important, very interesting. And we go for the next one. Next session is the sixth one, about antiplatelets and antithrombotic.